Welcome to PowerPoint number 6, Essentials of Health Information. This is out of Chapter 6, and we're going to talk about patient record documentation, guidelines, whether it's inpatient, outpatient, or the physician office. Healthcare providers, keep in mind, are responsible for maintaining a record for each patient who receives health services. And again, if we remember, they need to comply with standards from the Joint Commission and Medicare conditions of participation. Keep in mind your Medicare of conditions of participation. If you don't, again, follow their standards, they will not reimburse you for services. So again, the good thing about this, they provide guidance as to patient record content requirements. So again, the COP states that hospitals must have a medical record service that has administrative responsibility for medical records. They must maintain a medical record for each inpatient and outpatient. So if we talk about inpatient and outpatient, remember, outpatient is going to be emergency room, observation, ambulatory care, doctor visits. Those all are considered outpatient. To be an inpatient, you need to be in the hospital, typically over 24 hours, usually an overnight stay. So when going about that, they're also stating that everything must be accurately written, promptly completed, filed, properly retained, and accessible. The COP also states the hospital must use a system of author identification, record the maintenance that ensures the integrity of the authentication, and then protects the security of all record entries. It also must contain information to justify the admission and continued hospitalization. So should they've stayed in there for 5 days versus only being in 3. They'd have to support the diagnosis. What was the patient's progress? How did they respond to medications and different services they received? They have to be legible, complete, authenticated, and dated. We talked about this back in PowerPoint number 2. And again, the author must authenticate their entry. It must be retained in the original legally reproduced form for a period of at least 5 years. Again, this is retention, and this is retention from the COP. They must have a procedure for ensuring the confidentiality of patient records, and the original medical records must be released by the hospital only in accordance by state laws, federal, court orders, or subpoenas. Records must be retained for 5 years. The Joint Commission. They require a patient record contain patient-specific information appropriate to the care, treatment, and services. So as we go through this chapter, imagine the different types of data that's placed on forms, not the format. So what do we all put on an operative form? Any different forms, an emergency room form. Patient identification. So the record needs to be, again, all put for the patient's record must be the name, number, and the date of birth. It must include the patient's name, and it doesn't matter how many pages. Every page in that medical record has to have the patient's name and medical record number on it. And they also need to have facility identification, name of the facility, the mailing address, and telephone number. It must all be included on each report in the record. For a record to be admissible in the court of law, to the Uniform Rules of Evidence, all patient record entries must be dated in time. Anything that's predated or postdated, they're not allowed. So again, make sure you review these guidelines on page 133. Okay, let's talk about administrative data. So we're going to talk about face sheet, advance directives, informed consent, patient property form, a birth certificate, and death certificate. The face sheet's the first thing we're going to talk about. This contains patient identification or demographic, financial data, and clinical data. Usually your face sheet is going to be the first page of a paper record, and your computer-generated face sheet has the same information as a paper would. So even an electronic health record, the face sheet's going to still have the same information on it. The Joint Commission does not require a face sheet, but there has to be identifying information. Okay, so what do we need to submit to the Uniform Hospital Discharge Data Set? It is the minimum core data that's collected on individual hospital discharges for Medicare and Medicaid, and much of this information is located on the face sheet. Make sure you review the official set on page 136. And the reason being is because you will utilize this down the line for different assignments that we have. The face sheet. Review the different types of data on the face sheet: identification data, financial data, and clinical. All of your standards. The Joint Commission, we have the American Osteopathic Association, conditions of participation require that a medical record needs to be completed within 30 days of discharge. The COP requires a final diagnosis needs to be on the record within 30 days of discharge. These are different things that you will need to remember for your exam. Admitting diagnosis, provisional diagnosis. It is the condition or the disease for which the patient is being treated. Keep in mind, admitting is not often the patient's final diagnosis. Your final diagnosis is determined after evaluation and documented by the attending physician. So let's say they come in and they got admitted for chest pain. Okay. Again, after evaluation and tests are run, they figure out the patient is having a myocardial infarction. Principal diagnosis. It's the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So let's evaluate this. Patient comes in, once again, let's say for abdominal pain. Okay, and at this time the doctor puts down for provisional either appendicitis versus pancreatitis. Okay, so after study, after running test and test, the physician states, you know what, the white blood cell counts were low, it's looking like they're having appendicitis. That is now the principal diagnosis after study. Okay, again, principal diagnosis is after study. It's usually what they find out after running tests on the patient or blood work. Secondary diagnosis. These are additional conditions for which the patient received treatment and impacted the inpatient care. So with that, your secondary diagnosis continued. We have comorbidities. These are pre-existing. These conditions pre-exist because of its presence with a specific principal diagnosis, cause an increase of the patient's length of stay at least 1 day in 75% of the cases. So let's do an example here. A comorbidity is something that a patient has. So whether it's diabetes, hypertension, okay, but let's say they get admitted to the hospital for chest pain. Okay, and after study, they have a myocardial infarction, which is a heart attack. Okay, but since they have hypertension, which again is high blood pressure, which relates to the heart, this is a comorbidity. It's a pre-existing condition, but it caused them to stay in the hospital longer. Okay, so again, it's a condition that the patient has. Where a complication, this is something that arises after the beginning of hospital observation and treatment and modifies the course of the patient's illness. It prolongs the patient's length of stay, again, at least by 1 day in 75% of the cases. So let's say a patient comes in and has a hysterectomy. A day later, they start hemorrhaging. Okay, so you are going to code hemorrhaging. That's going to be a secondary diagnosis, but actually it's a complication. It's a complication of the surgery. So make sure you know the difference between those two. We do have a handout for diagnoses, so make sure you review that too. Procedures. Principal procedure is a procedure performed for definite or therapeutic reasons, rather than diagnostic purposes or to treat a complication, or that procedure which is mostly closely related to the principal diagnosis. Where second procedure, it's just an additional procedure that was performed. Okay, let's get into advanced directives. Patient Self-Determination Act of 1990 required that all healthcare facilities notify patients age 18 and over that they have the right to have an advance directive. This would be a healthcare proxy, a living will, a medical power of attorney. It's a legal document in which the patients provide instructions as to how they want to be treated in the event they become ill. There's no hope for recovery. So again, there's been examples in the news where people have had an advance directive. Okay, I'm sure you've heard of different situations where, possibly they're saying that the patient has no life left. Okay, there's not brain activity, but again, they're keeping them alive by on machines. So again, that's why a lot of times people do have the advance directives. DNR is do not resuscitate, do not perform CPR. Living will is the document in which patient states the kind of health care they do or do not want under circumstances. Healthcare proxy, durable power of attorney. Organ donation must be over 18 or have parental consent. And then organ or tissue donation. So what is an informed consent? Again, it's a surgery shall be part of the patient's chart before the surgery is performed. It has to be dated, timed, and signed by the patient and the physician. Consent to admission. It's a generalized consent that documents the patient's consent to receive treatment at the facility, which HIPAA states they don't require to obtain a consent for admission. But again, the surgery, yes, there is a requirement. And again, the patient's consent, receive medical treatment. One thing to remember with consents, with the surgery, you want a consent for surgery, any diagnostic therapeutic procedures, and it is actually the surgeon who should be discussing the procedure with the patient, explaining the risk, the complications. Should be a patient property form. All the items should be accounted for, signed by the patient and hospital member. Certificate of birth, record of birth information about newborns. This needs to go to the National Center for Health Statistics within 10 days of birth. Usually it's done electronically. Some are filed in the chart, but not always. And we have the certificate of death. This contains a record of information regarding, again, whoever passed away, his or family, the cause of death, disposition of the body, and the National Center for Health Statistics states that the death certificate signed by a physician with the State Department of Health Office of Vital Statistics, usually within 5 days of death. If anybody has any questions on this PowerPoint, please email me.